Chapter 33. This is part two. So this is like relating to like drownings and bites of like snakes and scorpions and ticks and stuff like that. And then we'll finish with a quick 10 question review at the end. So let's get going. So drowning, right? This isn't, I've seen them actually test the difference between these two definitions. So do know the difference between a drowning and a near drowning. But the drowning is a process of experiencing respiratory impairment from submersion or immersion in a liquid, okay? And so typically we think of drowning in like water, like a lake or the ocean or a pool. But something to know, two concepts. First one is drowning is silent. I think we think of the movies when a kid falls into a pool and they're slapping the water. That doesn't happen. I've seen twice at pool parties when I was younger, kids that would jump into the pool and they didn't know how to swim, they didn't have their floaties on, and they just sink straight to the bottom like a rock. And both times, my mother, who's a nurse and paramedic, yanked these kids out of the pool because no one else is paying attention. And so, be aware, drowning is silent. Number one. Number two, you can drown in as little as 3 inches of water. Okay, you literally just have to cover the nose and mouth. A kid's face down, especially a very small child, and they can drown. So be very aware of those two concepts. Those go against the norm of what we think when we think of drowning in like the movies and stuff like that. So some agencies may still use the term near drowning, okay, to refer to a patient who survives at least 24 hours after suffocation in water. And so this is basically the patient that was in the bottom of the pool. Someone yanked them out and they ended up living. So be aware of that, okay? And I'll throw another interesting a concept into this is that when someone jumps into a pool like that or like a water, they end up not getting a whole lot of water in their lungs. I think the average amount of water in the lungs from a drowning is like 15 to 30 milliliters, so not very much. And so the reason that is because the larynx, the vocal cords will slam shut. They spasm. We call that laryngospasm. And so this will inhibit a large amount of water making its way into the lungs. But even then, if the vocal cords slam shut, there is no air coming down or water, and so this you still die from suffocation. Okay, and so the risk factors of drowning are intuitive, right? These are people that are drunk, so alcohol consumption. If you have a seizure in the water and you're not wearing a flotation device, you're going to sink to the bottom. Geriatric patients with cardiovascular disease and unsupervised access to water. So again, drowning is silent. I cannot stress that enough. I ran a pediatric cardiac arrest in drowning. The kid ended up dying. I've ran two of them actually, two of them that I can think of. One was in a koi pond. A koi pond where they have little, like fish and stuff in a little pond at a trailer park of all places. And the kid died. It was like a 3-year-old actually died, and so we ended up working them. So just be aware, kids drown and they die. Unfortunately, very very tragic. Worked a lot of pediatric cardiac arrest when I worked at Cook Children's from drowning. Okay. So again, drowning is silent. Can't stress that enough. So now there's an interesting rule. I would never dive into a body of water where I can't see the bottom. So because of this, right? So if you dive into something head first, luckily your neck will break your fall, and you're going to break your neck. Okay, and so this is pretty common. So another public health notice: don't dive into water where you can't see the bottom of the surface. And so it's not the dive that'll kill you, it's the sudden stop at the end where your neck will break your fall. And so submersion incidents may be complicated by spinal fractures or spinal cord injuries. Okay, so assume a spinal injury of submersion resulted from a dive, mishap, or fall. So you might see this in a vignette: someone dived and didn't re-emerge, right? You may assume they broke their neck. The patient is unconscious. The patient complains of weakness, paralysis, or numbness. That all sounds like cervical spinal injury. And to be clear, actually, when I was in EMT school, maybe I was in paramedic school, I don't remember, it was paramedic school, a guy jumped off of Hell's Gate, which is like, I don't know how many 100 feet up in the air at Possum Kingdom Lake, and he fell feet first, right? And so he ended up rupturing his spleen and lacking his liver. And so he had internal abdominal bleeding, but he also broke his back in the lumbar region. So keep in mind, when you hit solid water from a height, I don't know what the height is, it kind of turns into concrete. And so you're still hitting something very fast, very hard. And so he ended up breaking his back as well. Young guy in his 20s. Okay. And so most spinal injuries and diving incidents affect the cervical spine, but again, it can affect the lumbar, but it makes sense. Typically we dive in head first. Why? I don't know. Like, our most vulnerable part is what we'll dive in first. And so stabilize the suspected injury while the patient is still in the water. There's a special technique to doing this, to where you'll put them on a backboard. But again, if the patient's in cardiac arrest or unconscious, we don't worry about that, right? The airway, breathing, circulation comes first. Now, water rescues are usually handled by specialized rescue personnel, right? There's this concept of reach, throw, and row, and only then go. So basically, you're going to try to reach out to the patient, then you're going to throw a flotation device, and then you're going to try to go out to them on like a boat or something, and then only then would you, if all those have failed, would you go get them? Okay. Um, so just keep that in mind. Or wait, it says do not let the person, oh yeah, don't let the person grab you. That's an important thing to know. Drowning people are frantic. And so you have to be careful that they don't shove you under the water and use you as their flotation device. Okay. So sometimes you actually have to you have to get pretty aggressive with how you grab them. But that's really not what this course, that's not what this course is focusing on. Okay. So if the patient is not floating or visible in the water, an organized rescue effort is necessary. Specialized personnel will go looking for this patient, and obviously at some point I've seen this tested. It'll transition from a rescue effort to a recovery effort. Okay, a rescue you're going to save someone. A recovery is you're going to find their body. So this is something I've seen tested as well. Never give up on resuscitating a cold water drowning victim. Remember in hypothermia, excuse me, um, when someone's cold, just like when we put steak in a refrigerator, it kind of preserves the tissue. And so hypothermia can protect the vital organs from the lack of oxygen. And so generally, if someone is cold and drowning, we would typically try to resuscitate that. Okay. Obviously, if they're frozen stiff, no, and have rigor mortis, no. But what I'm saying is generally, say they've been submerged in cold water for 30 minutes, you would still work that if you can find them quick enough. Okay. And so so there's a reflex that we actually use. This is called the diving reflex. And so basically, you may have experienced this when you jump into like a cold body of water and it sucks your breath away. That's one of the reflexes, and you'll experience bradycardia. Remember, bradycardia is the medical word for a low or a slower heart rate. And so do be aware of that. Slowing the heart rate caused by submersion in cold water, that is a thing. So generally, like I have a pool, or my old house did, and my brother has a pool. And so basically, if I were to jump in for the first time of the year, always jump into the shallow end because it could suck your breath away, or you could have like syncope or near syncope from the bradycardia reflex. The diving reflex will cause bradycardia. So we're going to talk about scuba diving injuries. And so I know some of our Weatherford, Texas students are going to get a little irritated with this portion of the book because we don't really have like scuba diving attractions. We don't have marine wildlife issues. We don't have high altitude sickness, but we're going to talk about all that today. But realize this is a national registry exam, and so we do have to cover these things, and they are tested. Okay, so just because we're in good old Weatherford, Texas, doesn't mean that we won't be tested on scuba diving and high altitude illness. Okay, and so a descent means you're going down. Okay, so do know the difference between that. So descent means you're going down. And so it's caused by the sudden increase in pressure as the person dives deeper into the water. They're diving deep. You see all these D's? Dive deep into water. You're descending. Okay? And so what happens is this gas gets compressed. Everything gets compressed. As you go about 30 feet below water, that's 1 atmosphere of pressure. And so as you go down to 60 feet, that's 2 atmospheres of pressure. If you go down to like 100 feet, you're greater than 3 atmospheres of pressure. So all of that pressure is 3 times greater than normal. And so you're taking, your lungs, they're normally full, and you're compressing it 3 times greater if you don't equalize. And so normally as we go down and when we're scuba diving, we're breathing, and with each breath, we're trying to equalize with the pressure. Okay, and so where you'll see these tissues that will be affected are tissues that have air in them, okay? And so your lungs obviously have air in them, and so that's getting compressed. Your sinus cavities, your middle ear, your teeth, your face, all of these things have air in them. And if that air does not equalize appropriately, because it's clogged from boogers or whatever, or like a cavity, for example, if you have like a cavity and there's a little bit of air in that filling between the filling and the cap, that will cause excruciating pain, especially as you ascend, as you go back up. And so just be aware of that. Anything that can hold air in the body can cause you some problems with scuba diving, okay? And so a descent emergency, the pain will force the diver to return to the surface to equalize the pressures, and the problem clears up by itself. And so when you scuba dive every around 3 meters, every 10 feet, you absolutely, it's really every meter, you have to like pop your ears. And so when you swallow, you hear that popping in your ears. That's opening a valve that's equalizing the pressure. And so when you're in an airplane and you're ascending going up, or when you're scuba diving and descending and going down, it's good to like on airplanes, I always chew gum to make sure my ears are equalizing appropriately. One and two, especially when you scuba dive. And so I've been scuba diving before. I'm certified to scuba dive. To where your ears don't equalize appropriately, and that hurts. So what you do is you have to go back up a little bit, swallow some spit, right, and try to pop, or you can squeeze down on your nose and blow out, and you can pop your ears that way. Okay. Now, if you don't do this appropriately and you ignore the pain, it's excruciatingly painful. You can perf your eardrum. So the tympanic membrane is this little thin membrane in your inner ear. Well, it's in your middle ear that can pop. Okay, and so when that pops, it's going to hurt extremely bad. And so the diver may lose his or her balance, shoot to the surface, and run into a scent problem. So this hurts so bad, the diver will shoot to the top because they'll panic, and it hurts. Imagine like the pressure of the ocean in your inner ear; it's going to hurt. And so just be aware. You can perf your middle ear, your tympanic membrane. Now, emergencies at the bottom; these are pretty rare. Usually, it's a fault with the diving gear, or you had inappropriate gas in your tank, or some type of equipment failure. Okay, and so this could cause drowning or rapid ascent. That's pretty obvious. Some of this stuff I'm going to fly through, so sorry, not sorry. But ascent emergencies, ascent means you're going up, right? You're going back up from the bottom of the ocean. Okay, and so um, this is where you can get into huge trouble. This can kill you. So going down, things are compressing. Okay, that's annoying. It's uncomfortable. But going up, imagine your lungs are 3 times the pressure that they once had. Okay, and if you were to shoot straight to the top and hold your breath, you would literally explode your lungs, because your lungs are going to explode or expand to 3 times their normal size. And if you're holding your breath, they're going to blow up, like literally blow up like a balloon and explode. And so this is very, very dangerous when this happens. And so ascent is where you really have to be careful as a scuba diver. And so just be aware of that. Ascent is where you'll run into some real life-threatening emergencies. And so you can get what's called an air embolism. Okay. Let me just tell you quickly. The other way this can happen is if I were to take like a big syringe of air and inject it into your IV. That's the same thing. That's air that's moving in your veins or your vessels. So that's an air embolism. Okay. And so what happens is as you go up, there's gas in our blood, right? Oxygen, nitrogen, right? Carbon dioxide. As you go up from the bottom of the ocean to up, that gas goes from little bubbles to big bubbles. And if enough big bubbles accumulate, you can get one really big bubble, and that one really big bubble can turn into an embolism. And so that's how you get an air embolism. And so just be aware of that. That can be very, very fatal. Because imagine you have a bunch of air just going to your heart instead of blood, right? You're going to die. Same thing to your brain, or really anywhere, right? So you could kill someone. There's been documentaries of paramedics and nurses killing patients before, accidentally or on purpose, by injecting air on accident or on purpose. So there is this thing called decompression sickness. This is also called the bends. And so be aware that the majority of the air we breathe is nitrogen, okay? And so there's going to be bubbles of gas, namely nitrogen. Watch for that on a test. It's nitrogen, not oxygen, not carbon dioxide. It's nitrogen, okay? That's a big N on the periodic table. And so nitrogen can expand, and when it expands, these little bubbles, they can get stuck in your vessels, and namely, they like to get stuck in your joints, like your elbows and knees and stuff like that, fingers. And so it's when you, again, go up too quickly, and so what you do, the patient will complain of joint pain. It's very painful. This can be, in extreme cases, fatal, but that would be an air embolism. But this is fairly, I wouldn't say common, but probably the most common diving injury we get is someone will get the bends. They'll get bent. And so this is also called decompression sickness. Now think about it. Compression at the bottom of the ocean. You're compressed 3 times the atmosphere of the Earth. And so if you were to quickly go up, you're decompressing. You go from 3 atmospheres, 2 atmospheres, 1 atmosphere to 0 atmospheres. And so as you do that really quick, you're decompressing. So that's why it's called decompression sickness. Okay. So nitrogen will get stuck in the vessels, namely in the joints, okay? And so it blocks these tiny blood vessels. This hurts really bad. You'll get abdominal pain for sure, but joint pain. It's where you watch out if they tell you someone went scuba diving and now their joints hurt, it's the bends, okay? And so they'll be doubled over in pain. This is very painful. Now, it really wouldn't be a huge task to distinguish between air embolism and decompression sickness. Again, these happen the same concept where gas that was once compressed in your blood becomes really big gas bubbles from ascending too quickly. And so, generally, uh, 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 and air embolism is going to be very like rapid, right? One really big bubble, or the really big bubble causes the air embolism. You're going to see immediate signs and symptoms. Now, the bends is usually going to be a little bit further out. Okay, so like it's on the boat ride back to the dock, or when they get to the dock, they're like, "Oh shit, I hurt," and so just be aware of that, and that's called the bends. Okay, decompression sickness, and so interestingly, the treatment for the bends, we don't actually do this that often, not as often as you think, but the book wants you to know that you can recompress someone in a hyperbaric chamber. And so there's these chambers that exist like this. You slide a bed in there where a patient can sit in there. And what you do is you pump that chamber with pressurized air. And so as you pump it with full of air, you're recompressing the gas in the body. And so what you do is you recompress them and then you slowly decompress them over a period of like hours or days. And so that is called a hyperbaric chamber. Dallas Parkland has one of these. If you're a hospital on the coast, you certainly have one of these, just because this is how this is treated. Okay. Now, I'll have you know it's actually not that common for this to happen, but it is the textbook treatment for this. Okay. Generally, the bends, if it's not super severe, you'll let them ride it out. They're gonna hurt like crazy and just ride it out. But if the textbook answers, you would put them in a hyperbaric chamber. Okay. And so, with any scene safety, right? Gloves and eye protection. Never drive through moving water. Oh my gosh, don't. We're not. And something about flashing lights and sirens make people think they're invincible, right? And so they're immortal, but you're not. Okay. And so. Moving water will sweep away your ambulance, I promise. And so be cautious driving through still water or any type of water. As they say, I have a slogan I made up, and TS TxDOT stole it from me. I think it's called "Turn Around, Don't Drown," and they stole that from me back in about the early '90s. And so, turn around, don't drown. So never attempt a water rescue without proper training and equipment. Remember, when you take this exam, you are not a firefighter, you are not a swift water technician, you are an EMT student. And so don't turn off your firefighter mind when you're doing stuff, taking these exams. Remember, consider spinal or trauma and spinal mobilizations, especially in submersion incidents, and check for additional patients. So, you'll form your general impression. What's your general impression? This is across the room assessment. And so pay attention to chest pain, dyspnea, complaints of sensory changes, APU scale. Be suspicious of drug or alcohol use. You'll see this in drownings. Again, um, drunk people drown. Okay. It's because they can't swim. They're impaired. And so, you know, I don't like telling a lot of stories because it's gonna be a long video anyways, but there was a lady at Possum Kingdom Lake. If you don't know, big boats have generators to keep like the air conditioning and stuff going, like moderately like a yacht or something. And so in Hell's Gate, we tie up with like all the boats, and so there's a lot of generators running. Well, carbon monoxide is fairly heavy, so it will settle over the top of the water. Well, if it's a still day inside of a canyon, Hell's Gate, um, that can become toxic. And well, this lady was drunk, and apparently she got too close to the generator for a long period of time, and she died from carbon monoxide poisoning and sunk to the bottom. And so she ended up dying, of course. And so just be aware that that's something to consider too. If she was drunk, maybe she would have recognized like, oh wow, I feel dizzy and I have a headache, and I'm cherry red, so I should probably get away. And but when you're impaired, you don't make reasoning like that, and so you die, unfortunately. Okay. And so consider trauma or spinal trauma, and you would take appropriate actions. You would suction the patient if they vomit. Vomiting is very common in submersion incidents. Okay, all the drownings I've ever worked, they did vomit, large amounts of vomit. Okay, provide ventilation with a BVM for inadequate breathing. If the patient is responsive, provide high flow oxygen with a non-breathing mask. Auscultate and monitor breath sounds. Okay. Circulation. It may be difficult to find a pulse. Begin CPR, apply your AED. Remember, you'd want to wipe the patient dry, at least their chest, before using the AED and applying the pads. Evaluate for shock reperfusion, right? Again, you have to consider the MOI. If someone jumped into a pool of water, if there was jumping involved, you need to think there's spinal injury, okay? Um, Always transport near drowning patients to the hospital. The reason for this is because look, inhalation of any amount of fluid can lead to delayed complications, specifically pulmonary edema, which is fluid or swelling of the lungs after the fact. Especially if it's like lake water or salt water, really any water, pool water. Other than like bath water, you're going to end up with some serious issues with like fluid shifts. Also, pneumonia. So if someone nearly drowns in like a pond, like a tank or a pond or a lake, lot likely to get sick compared to like a pool. There's a lot of bacteria and protozoa in a pond. And so the chances of you getting pneumonia after near drowning is like astronomically high. Like it's, especially in like a lake or a pond. Okay? Excuse me. So, take a history. Obviously, if they're unresponsive, you're going to have to get this from the bystanders or the family. Okay. Determine the depth. If this is diving, how deep did you go? Some people will wear like dive computers. They're like a watch that'll tell you how far they went, how long they were at that depth, how quickly they ascended. There's a lot of data you can get from those. Length of time the patient was underwater, time of onset of symptoms and previous diving activity. Now, and the reason previous diving activity, if you dive like 3 or 4 times in one day. So like you spend 4 hours submerged, right? To scuba diving, like tourists, uh, and you decide, oh, I'm going to fly home that night on an airplane, or the next morning I'm going to fly back to the United States or whatever. You can still get the bends because there's still nitrogen in your blood, and so if you go really quickly up into the air and you're ascending even further, less pressure, you can still get bent. So generally, you don't want to go flying within 24 hours of your last dive. Okay, so that's another way you can get the bends, also known as decompression sickness. And so, how we combat decompression sickness is as you go up slowly, right? So you'll go up and around like 1 atmosphere of pressure. You'll hang out there like 5, 10 minutes, sometimes longer, and you'll sit there and wait for the adjustment of your body, right, to decompress while you're still under a little bit of pressure, and then you'll make it up to the surface. So that's how it's supposed to be done. So when you go scuba diving greater than like 60 feet, typically, you have to, it's called a safety stop, where you'll stop at like 15, 30 feet, 15-ish feet usually, and just sit there for like 5, 10 minutes. So uh, they're saying the same thing. I'm not reading that. And so assess for peripheral pulses, skin color and discoloration, itching, pain. Paresthesias is the feeling of like numbness and tingling. You felt this if your arm's ever fallen asleep, right? I have a bad thing where I sleep on my arm and I'll wake up and it's like completely numb and swollen in a sleep. And so that's the feeling of paresthesias. Okay? Paresthesia. Sophisticated word, right? Paresthesia. And it's basically, think of like, oh, that's when my arm falls asleep. That's what it feels like. It's kind of numb and tingly. Okay? And so of course, do your vital signs, pupil size, assess oxygen, right? Now, one thing to add is oxygen saturation could be inaccurate if they're cold, right? So remember, when we're cold, we shunt blood to our core. And so it's no different if it's cold outside or it's cold inside a pool or the ocean. You'll shunt blood from your fingertips, where we'd be sampling, with a pulse oximetry to your core. And so you may not get an accurate reading that way. Okay, same with cap refill. Now, this is what it's saying. Drowning patients may deteriorate rapidly due to the pulmonary injury, right? Pulmonary edema, a fluid shift in the body, especially in the case of like an ocean drowning with salt water. This can also happen with cerebral hypoxia. So as the brain is dying and hypoxic, you can end up with the brain will swell. Okay, and so that's a general concept. When tissues go without oxygen, they swell because the ATP pump isn't working. The sodium potassium pump stops working, so cells will swell and lyse and explode. And so that especially happens in the brain. So you get cerebral hypoxia and cerebral edema, and then hypothermia. Okay. Now, like I was saying, if you go up too quickly, you can, and you were to hold your breath, right, from like a scuba diving thing, you can actually pop your lung, and so that would lead to a pneumothorax. And in fact, you could have a bilateral pneumothorax, so that would be incredibly bad. So be aware of that. Okay, this would be one of the few times I would say that you could actually get a bilateral pneumothorax. So again, document the circumstances of drowning and the extrication, who did it, how long it took, what devices were used, how long they were submerged, the temperature and clarity of the water, meaning, oh, the water was murky brown or it was clear or whatever. If there was a possible spinal injury. So again, if there was any type of jumping into the water or falling into the water, you need to suspect spinal injury. Okay. Bring all dive equipment to the hospital, including the dive log or a dive computer. Okay, again, dive computers are not like a Macintosh, right? Uh, or an iPad. They usually look like watches. It's like a watch that the patient will wear on their wrist. So, of course, immobilize and protect the patient's spine if a fall or a diving injury is possible. I've said that about 8 times. If the patient is not breathing, do CPR, right? You're going to use a BVM, then you're going to use chest compressions, use an AED, and treat for hypothermia. Okay, we would passively warm these patients. For an air embolism or decompression sickness in a conscious patient, you're going to remove the patient from the water. Try to keep the patient calm. Administer oxygen. Consider the possibility of a pneumothorax. So remember, if they ascended quick enough to get an air embolism, they theoretically ascended quick enough to get a pneumo. So be aware of that and promptly transport. Now, pay close attention to the body temperature. I feel like I'm reading this one to you, but I'm sorry. I mean, I just don't have a lot to add. Uh, pay close attention to the body temperature of a person who is rescued from the cold water. So you'd want to check the temperature even on a fairly mild day. If you're submerged completely in even like fairly like comfortable water, like at 80 degrees, you could cool the body off to 80 degrees. That's hypothermia. And so be aware of that. So it's a best practice to check temperature in any type of submersion incident. Okay. And so breath holding syncope. I used to do this as a kid. It's crazy. So a person swimming in shallow water may experience a loss of consciousness caused by a decreased stimulus for breathing. More so, they're talking about something different. What I'm saying is like as a kid, like, oh, how long can you hold your breath? That's crazy. We used to do that. But treatment is the same as a drowning patient. And so just be aware that uh, uh, if, if, if you were in water, you could end up holding your breath again and not having that by the decreased stimulus for breathing, and still that's asphyxiation, and you're still going to go into cardiac arrest because of hypoxia. So the treatment's the same as drowning, right? Establish an airway, ventilate, CPR, AED, keep them warm, transport. So general public health warning interest. Okay, I've talked about this. Drowning is silent. It is a very preventable cause of death. Turn around, don't drown. Been saying that since the late 80s. And so all pools should be surrounded by a fence. The most common problem in child drowning is a lack of adult supervision. I'll take it a step further of sober and adults actually supervising supervision. Half of all teenage and adult drownings are associated with use of alcohol. So I'm a big fan of smoking some beers and swimming, but know your limit, right? And so be aware that impaired people make impaired decisions. And so, I mean, you got to know when to hold them, know when to fold them. I'm not advocating for you to drink and swim, but people should know their limits, or at least have a responsible party watching them. Now, something I'm not well versed in, the rest of this stuff, I've tried to prepare, but let's talk about high altitude and snake bites. I hate snakes. So high altitude, so I will tell you this word baryism, okay, it means pressure. And so the word dysbaryism is meaning an off pressure, right? So something's wrong with the pressure. And so caused by the difference between the surrounding atmosphere pressure and the total gas pressure in the body. And so something to realize is at sea level, oxygen is 21% of the air we're breathing. The rest of it's nitrogen pretty much. And so as you go up in altitude, that 21% decreases. I used to remember how much it decreased, but it's fairly significant. I think it's like 1 or 2% for each like 10,000 feet. I think I should have looked that up. But anyways, as you go up in the mountains, you'll get short of breath. And like this little Texas boy, right? I'm living at sea level my whole life. If I go to Colorado to go ski, I'm sucking wind for the first few days. I remember the first time I went skiing, it was very scary because I was going to play in the snow, and I got very short of breath and almost passed out because you were out there playing and stuff, and you're not used to that thin air. Okay, and so be aware of that. It's scary. So of course, where are you going to see these affect first? The nervous system. That's why I was dizzy and felt like I was going to pass out. And the pulmonary system, the cardiac system. Okay. And so acute mountain sickness is diminished oxygen in the air at higher altitudes. Okay. So be aware of that. If they tell you the patient's in the mountains, the patient went skiing, the patient's in Colorado, New Mexico, Utah, something like that, okay? The Appalachians. And so caused by ascending too fast or too high, too fast, or not being acclimatized to high altitudes. I was all of those things, right? And so if you're in this class, you're probably from Texas, so you're not used to being in the mountains. So you're going to be short of breath if you try to go running or playing in the snow or something like that. So over time, you'll adjust to this, but just be aware that's called acute, meaning it's rather sudden, mountain sickness. And so the headaches are headache, lightheadedness. Like I said, I was like dizzy and fatigue. You'll be very short of breath and worn out. Okay. I don't know if I've ever slept better than after going skiing or something like that. You're just worn out that night. So good sleep. Now, acute mountain sickness and signs and symptoms, right? Loss of appetite, nausea, difficulty sleeping, shortness of breath during physical exertion, a swollen face. And so, in fact, if you ever go to like a ski town, a lot of times they'll have like oxygen bars and stuff where you can pay a little money and just go sit there with a nasal cannula on. Sometimes they'll put like, bubble gum scent or like, I don't know, apple or vanilla, and you'll just sit there and breathe oxygen on a nasal cannula. So I've never done that, but I've seen those offered when I went skiing in the mountains and stuff. And so there's this thing called high altitude pulmonary edema. And so this is when pulmonary edema is swelling of the lungs. And so this will happen when fluid collects in the lungs, hindering the passage of oxygen into the bloodstream. And so this is pulmonary edema from high altitude, right? And so you're going to see the typical signs and symptoms of high altitude sickness of shortness of breath, pulmonary edema, shortness of breath, cough with pink sputum. That only means one thing on an exam, folks. That means pulmonary, that's not how you spell it, edema. Okay, so if they tell you someone's coughing pink sputum, that means one thing, or coughing up pink frothy sputum, anything like that, pulmonary edema. Okay, we normally see pulmonary edema in left-sided heart failure or congestive heart failure, but you can certainly have this with high altitude sickness. Okay, cyanosis. What's cyanosis? I happen to be using the right color pen. It's bluish purple tint of the skin, and a rapid pulse. Okay, now this could also be accompanied with high altitude cerebral edema, and so may accompany the high altitude pulmonary edema. Cerebral means brain, right? Pulmonary means lungs, and so high altitude cerebral edema or high altitude brain swelling would be what it sounds like. You're going to get severe constant throbbing headache, ataxia. What's ataxia? Someone who's ataxic has uncoordinated movement. And so someone who's drunk is ataxic. Okay, so that could give you an example. Like the way they move. Extreme fatigue, vomiting, loss of consciousness. Okay, so if I were to say put these in order of severity, which one of these are more severe? Acute mountain sickness, HAPE or HACE, right? It's going to be probably HACE, the brain, and then the lungs, and then acute mountain sickness in order of severity. Okay, so be aware of that. Now, provide oxygen. They're going to want to descend these patients from height. Now, oxygen will, interestingly, like a non-rebreather, will fix a lot of this actually fairly quickly. So oxygen is by far the most important treatment you could do for these patients, okay? Transport them promptly, and sometimes you might have to provide positive pressure ventilations. Watch for this in exams where they'll say, the patient's in the mountains, they're vomiting, pulmonary edema, pink frothy sputum, loss of consciousness. What do you do? Oh, and they add the detail. They have slow irregular respirations, or they have irregular respirations, or they have shallow respirations. If they throw any of those words in there, we know by now, on this point of the course, that means you need to use positive pressure ventilations, namely with a BVM, right? Where we do the CE clamp and we're ventilating the patient, okay? And so that's it for the altitude stuff. Now, lightning, this is an interesting thing because it goes against the norm. So lightning, interestingly, is the 5th most common cause of death from isolated environmental phenomena, okay? And so targets of direct lightning strikes are people engaged in outdoor activities or anyone in a large open area. And so, lightning will find the path of least resistance. So if you're standing in an open field and you're 6 feet tall and the grass around you is 6 inches tall, your head is going to act like a lightning rod and you're going to get struck with lightning. And so, obviously, this is why when there's lightning, you need to get to shelter. Okay. And so, many individuals are struck when standing near an object that has been struck with lightning, such as a tree. So the same thing can happen. If this is a tree and this is you, right? If lightning kachowies this tree, it'll travel through. And again, if it finds the path of least resistance is through your head and down to the ground instead of this big, thick tree trunk, that's what it will do. Okay? So standing under a tree is still probably not a great idea when it's lightning or standing out in the open. So how do we fix this? Just get out of the open, like go inside, go to shelter. Okay? So now the thing about a lightning strike is it throws the heart into ventricular fibrillation, where the heart will sit there and quiver. Okay, so it doesn't flatline like a systole; it'll sit there and quiver like this, right? So you'll see that on the monitor, and so it'll quiver like this. The heart's just shaking, and so interestingly, when the heart's shaking like that, the treatment is early defibrillation, right? We can defibrillate with more electricity, right? Defibrillate with an AED and CPR. Okay, and so we know when someone's heart is shaking like that, it's actually pretty easy to save them and get them back with good neurological outcome. So it goes against this. Let me go to this real quick. Um, uh, Idea of reverse triage. Whoops. And so reverse triage says, um, if say there's an outdoor concert and it started hailing and lightning, and 2 patients are in cardiac arrest, and 3 patients are walking wounded, and 1 patient is bleeding severely from the head. Who are you going to care for first? Typically, you would say the patient that's bleeding severely from the head. That's a red patient, right? But in this case, you don't. Because if you suspect that in an MCI where you're triaging patients, someone has been struck by lightning, you can actually move them to the very top of the list, and you're going to care for them first. So lightning strikes are the only time that black patients that are dead, not breathing, move to the very top of the list where we're going to care for them first. Because normally, like, let's say it's a bus rollover, right? And you got like 3 dead people and 4 reds and 3 yellows and 2 greens. Normally, you would care for the red patients first because the blacks are dead. They're gone. We're not working on them. We're not going to spend resources on dead people. But not in this case. Lightning is the exception to that. So we call that reverse triage. You're reversing the order to where typically black people are the very last people we worry about, right? When I say black people, by the way, I'm speaking about their triage tag, not someone of color. There's been issues with that in the past where it's created problems on like radio traffic and stuff. I'm saying black patients as in their triage color. I should be very clear on that. Don't cancel me. And so what I'm saying is a black patient, like a black triage tag patient, when lightning is involved, they're our very first priority. Why is that? Because if we defibrillate these patients and provide CPR, they are very, very likely to get them back to survive. So we want to treat them very quickly. Okay, so this concept, which is heavily tested, is called reverse triage. Now, with that, with lightning burns, there's different levels of this. I had a lady say she felt her lightning really did strike her house and catch it on fire. And she said she felt tingling and stuff. And so I guess that would be a mild lightning strike for her. But a moderate would be the burns, seizure, respiratory arrest, dysrhythmia, and a severe one would be full-blown cardiac arrest. So there's different levels, okay? But, that's pretty obvious. So move the patient to a sheltered area. Assist ventilations or use an AED, control bleeding and transport. Now, the burns of a lightning strike can be very impressive, right? So remember, the entry wound will be usually a little bit smaller, so let's say you got struck right in the top of your head. And so that wound will be significant but fairly small compared to the one in your feet where it blows out, right? It's almost like an entry wound from a bullet's pretty small, an exit wound of a bullet's very large. And so that's the same concept here, okay? Same concept. And so you have to worry about burns and kidney injury and nervous system injury. And so something to keep in mind is that high amount of energy traveled from their head all the way down to their toe. So there's damage from here to their toe and all along that pathway. And so keep that in mind. With lightning, there's a significant internal damage and bleeding, or not bleeding, internal damage, tissue damage from the energy. Because again, it traveled all the way from wherever they were hit to where it escaped. So don't forget about reverse triage. Black patients are triaged, or we treat them first. Let me go back. The other word for a black patient, something we're seeing now, more common, they don't call them black patients. Let me just tell you a story. There was some radio trap, like they're at an MCI and they went back and listened to the traffic, right? The recording of the radios, and they're like, all right, We got three black patients we're not going to work. We have two red patients and one yellow. And so of course, people went back and they're like, wow, they're not treating black patients, like patients that are black, African, right? People of color. And that's not what they're saying. They're saying that patients that are triage tag black, we typically don't work them because they're dead. It has nothing to do with their skin color. And so now we're changing that to the word expectant, right? So you might sometimes see this on exams that instead of saying black, like what I'm saying, that's what I was taught, and that's still what we use. They'll say they're expectant, right? Like they're expectant. You're expecting them to die. And so we don't really work them usually. Unless they have been struck by lightning, they move to the very top of the list. Because normally the triage priority would go like in a normal MCI, like a rollover, red, yellow, green, black. In a lightning strike, it goes black, the dead people we work first, then the red, then the yellow, then the green. So spider bites, I don't like spiders or snakes. They're gross. And so there's a lot of spiders in the United States, okay? I feel like everything in the United States is trying to kill you. That and Australia. Everything in Australia is trying to kill you. And so it's like all spiky and thorny. So only the female black widow spider and the brown recluse spider deliver serious or life-threatening bites in the United States. And so that's kind of worth knowing, right? And so if they tell you like, oh, a tarantula bit me, or, you know, I don't know, a wolf spider or something like that, yeah, that's a problem. It's not great. You can certainly get infection from that, a little bit of necrosis. But it's usually not life-threatening. Now, a black widow and a brown recluse spider, these can be lethal, okay? And so this is a black widow spider. They sick me out just looking at them. And so you can see that they have this little hourglass red shaped thing on their back. We do have these in Texas. And so it's like this bright reddish orange hourglass sharking on their they're calling their abdomen. Okay. The female is fairly large and it can measure approximately 2 inches across. This makes me all like tingly and gross talking about this. And so usually it's black with a distinctive red orange marking in the shape of an hourglass on its abdomen. And so they're found in every state except Alaska. Okay. And so they prefer dry, dim places. So, these are going to like be up underneath a desk or under a chair or, in an old vehicle that you haven't, or, in the tractor seat or something like that, right? And so the interesting thing is most bites, the bite can be overlooked because the initial bite can at times be not very painful. But most bites they can cause localized pain. The symptoms include agonizing muscle spasms because this is a neurotoxin. And so the main danger of this venom, which is it's poisonous to the nerve tissue. So when you hear black widow, you need to think neurotoxic. So it messes with the nervous system. And so, of course, you're going to see neurotype symptoms: dizziness, sweating, nausea, vomiting, rashes, tightness in the chest, and severe cramps. Why the cramps and why the tightness in the chest? Well, what's telling you to breathe? The nervous system. What's telling your muscles to contract or not? The nervous system. So if those get impaired, that's where you see these symptoms, okay? And so generally these symptoms will subside over 48 hours, but really the treatment's just BLS care, supportive care. Sometimes you can end up with respiratory distress if it's a large dose. You might have to support their ventilatory effort if it's impaired because of this neurotoxin, but that would be exceptionally rare. And so a brown recluse spider, these are common in the South. You've probably seen these. And so brown recluse spiders are dull brown and have a dark violin-shaped mark on their back. Okay. Um, they live mostly in the southern part of the states, and so they tend to be in dark areas. And so the problem with this is they're cytotoxic. So remember, black widows, neurotoxin. These are cytotoxic. So what happens is the toxin causes tissue necrosis, and so this tissue will die. And so when this tissue dies, it becomes necrotic and infected and all these issues. And so this is where you can end up with these problems. It's tissue necrosis, the tissue will die. As opposed to black widow spider, it's neurotoxic, right? So it's nervous system issues. This is actual soft tissue damage, okay? And so that's kind of the issues with these. I actually had a friend that got bit one of these on like his shin, and he got a wicked staph infection. Like I've seen it worse now, but at the time I had never seen anything that bad. And so they had to wound pack it for a long period of time. And so where I would say this becomes actually probably more fatal is the infection after a brown recluse bite. That's usually the issue with a brown recluse bite is the infection because of the soft tissue damage. And they're also known to carry staph on them as well. And so, or you're, let me say this, you're known to get staph infections after a brown recluse bite because of the tissue necrosis. And so, um, a Hymenoptera stings, I don't know what these are. Bees, wasps, yellow jackets, ants, right? These things are painful, but usually not a medical emergency. So remember, you remove the stinger with like a firmage item like a credit card, and you scrape like this, right? And because there's a like a bee. If this is your skin and this is a stinger up underneath your skin, remember at the end of this, there's like a little poison sac that's pulsating. And so if you were to go in there with tweezers and grab this puppy and squeeze down on it, you're going to squeeze the venom sac. So you don't want to do that. So the idea is you take your little credit card and you whack, whack, and you try to whack it out. Okay. Now, anaphylaxis is a very real concern. Again, I know I've had patients, and I actually have a friend who is incredibly allergic to bees. And like one bee sting, or not bee, a fire ants. He's allergic to fire ants. And so one fire ant sting can kill this kid. Like he goes into true anaphylaxis. He's not a kid anymore, but be aware of that. This is a true issue for some people, the anaphylaxis of this. What's the treatment for anaphylaxis? Epinephrine. What's the dose of epinephrine? Through an auto-injector, 0.3 milligrams. What's the other medications? Albuterol. What's the other medications? Diphenhydramine, also known as Benadryl, 50 milligrams. Oh, I hate snake bites. So of the approximately 100, we've ran these, of the approximately 115 different species of snakes in the United States, all of them are venomous. No, I'm just kidding. Only 19 of them are venomous. I hate them all. And so I know this is going to like rub someone so wrong who's listening to this. Like, oh, I love snakes. I don't like snakes. And so rattlesnakes, copperheads, cottonmouths, water moccasins, coral snakes, anacondas, king cobras, right? They're all deadly. They're all scary. And so, but in all seriousness, these ones right here actually have very potent venom. And we're going to talk about what this venom is and how we treat it. And actually, all of these are found in Texas. All of them, and fairly common. Oh, I hate snakes. So this is a rattlesnake because of the little rattler on their tail. This one is going to be a copperhead by its copperish color. This one is a water moccasin, okay, or also known as a cottonmouth, okay, and this one is a coral snake. I used to know the rhyme. Someone help me out. It's like, let's see, black and yellow kill a fella, something like that. There's a rhyme. I don't remember what it is. One of these is really deadly, like the coral snake is deadly. And then there's another one that mimics this, but the color pattern is a little different. I don't remember what that color pattern is. They're all deadly. I don't like them. So anyways, no, but for real, a coral snake is very, very deadly. I think it's the most venomous out of all of these. But there's a snake that's like closely related, and it is like it's like a different color. I don't remember. And so snakes usually do not bite unless provoked. I beg to differ. Angered or potentially or accidentally injured. And I will say, actually, the snake bites I've ran, like the most recent one I can think of was this guy at Hillbilly Haven who saw a freaking copperhead on the beach, and he kicked it with a sand. He was wearing a flip flop. Well, it was a baby copperhead at that. So they have a lot of venom, I guess, when they're babies. And so it bit his big toe, and boy, did it bite his big toe! It got a good hit. And his whole foot was majorly swollen and painful, and he was drunk and screaming in pain. And so, yeah, moral of the story: don't kick snakes in flip flops. And so, yeah, I will say you do have to provoke these typically. Now, the provocation could be accidental, right? Because like you accidentally step on a snake or something like that, you're probably gonna get bit. So be careful, right? At the recording of this video, this is May 3rd, and so it's snake season in Texas, and so snakes are coming out, right? And so be careful for snakes. So protect yourself from getting bitten. Use extreme caution and wear the proper PPE. How about this? Just don't get me near the snake. Bring the patient to me. And so there's this classic appearance of a poisonous snake bite where you'll see two small puncture wounds and discoloration, swelling, and pain. And so I have a picture right here. And so I'm going to guess she got bit right there on the toe. and you can see a puncture mark right here. See that? And so you would assume she got bit here and it traveled in this way. Okay, looks very similar to the guy that got bit at Hillbilly Haven. And so I'm not making that name up, by the way. That's like a popular RV park on the Brazos River in our service area. And so pit vipers are these uh, the poisonous types of snakes. And let me tell you this: the pit vipers have fangs, right? Right, fangs. And so uh, a, a non-venomous snake, more so, they have these little nasty teeth. To where if someone gets bit, the bite looks more like this, like it looks like a bite mark, compared to if someone gets bit by like a pit viper, like a rattlesnake or something like that, it looks more like this. Okay, and so that's the difference between the two. So those two puncture marks are very hallmark. Now, could they have only punctured one fang into the skin, and is it still a good strike? Yes. Now, can you be striked by a pit viper and not get venom? Yes. And so there's variables to this, but just be aware of that, okay? And so why do they call these pit vipers? Apparently it's because they have this little pit right here in their nose, okay? I hate snakes. And so I will say the triangular shaped head, like a triangle, that's the poisonous ones. Some of them that have a more rounded head are not poisonous, but if they have a triangular head, they're poisonous. And I almost feel like a hypocrite teaching this to you because I'm not great teaching. Like, I don't like this stuff. But anyways, I'll quit saying that. I don't like snakes. And so rattlesnakes are the most common form of a pit viper. They come in many different colors and type. The diamondback rattlesnake is, I think, is what's common here in the or in Texas. They can grow up to 6 feet or longer, terrifying. And so the reason they're called a rattlesnake is because, again, they'll rattle their tail as a warning when they feel threatened. And so copperheads are usually a lot smaller snakes, like 2 to 3 feet. And then so like they're this reddish color. This is a copperhead. And so they're not as long, but copperheads are very common here in Texas too. We used to kill them all the time at my dad's house. My brother shot a rattlesnake the other day, actually, at his flight school. Yeah, with a 22. And so he now keeps a 22. He has like a silenced 22 that he keeps up at his. He owns a flight school. Anyways, yeah. So they're out. It's Maytime. They're moving. And I'm sure someone's like, no, don't kill them. They're good. They're not. And so copperheads, their bite is almost never fatal, but the venom can cause significant damage to the extremities because of the swelling and tissue necrosis. Okay, very, very painful. Now, cottonmouths, these are water moccasins is the other name for these. These are very aggressive snakes. These are the suckers that'll chase you in the Brazos River. Okay, like literally, these snakes don't just like, oh, okay, there's a human, I'm gonna go the other way. They're like, oh, there's a human, I'm gonna attack them. And so, for real, I'm not being funny. Water moccasins will actually attack you. They're aggressive, and so their bite is very toxic, and so it causes again tissue necrosis around the area of the bite, swelling, pain, and so in all seriousness, water moccasins are very, very aggressive. Okay. Another reason I will not be swimming in the Brazos River or any river. Well, any river that has snakes. And so, anyway, signs of envenomation. So, where I've ran this before is the snakes, or the bite hurts. It's very swollen, it's very painful. And you'll see this huge area swelling. And so it'll start bruising. So what happens is this causes the blood, the blood vessels to open up. So you'll get this huge area, like this inflammatory response, to where you'll get huge amount of swelling. The blood becomes very thin. Okay, in some of these bites, the pit viper bites, and so you'll get the swelling, this pain, this burning, nausea and vomiting, sweating, seizures, fainting. Okay, and so you can get vision problems, loss of consciousness, shock, right? And so this is a true snake bite. And so again, these aren't typically fatal, but if this is like an old person or a diabetic or someone with peripheral artery disease or vascular disease, this can lead to gangrene, right? This can lead to infection. And so you have to worry about like how is this going to heal up. This looks like a pretty healthy foot. But what I'm saying is this is what you have to worry about when like old people or diabetics get bitten with snakes. Like that can lead to their demise, like sepsis and infection and gangrene or amputation or something like that. And so what I want to point out is what you do is when you get on scene and you've stabilized the patient or whatever, you mark the area of swelling and you'll mark what time that was. So like around scene at it's 109. And so I'll mark this area, and sometimes you'll even mark like on the patient's foot or somewhere it needs to be documented. At 109, the swelling was this far, okay? And that way when you get to the hospital at 130, if it's this far, you're like, oh, it's still swelling. But we also use that as a guide, oh, it's regressing, it's getting smaller. So we mark the area of swelling from bites, okay? Same thing with spider bites or snake bites. We mark the area of swelling. It's a common concept, okay? And so the treatment is you keep the patient calm. You could locate the bite area and gently clean it with soap and water. So if there's anaphylaxis, you treat it with anaphylaxis with epinephrine. We've talked about that. But you don't give anything by mouth, and be alert for vomiting. Vomiting is a common side effect of a snake bite. And so you don't want to give them like water or something by mouth because it puts them at a higher risk of vomiting or aspirating. Remember, aspirating is when you choke on your vomit. And so just be aware of that. And so if the bite occurred in the trunk, keep the patient supine and quiet and transport as quickly as possible. The reason you have to worry about the trunk is there's some important stuff in the trunk, i.e. the heart and lungs, the diaphragm. And so you have to worry about those things being infected or necrosis of that area, like the guts, okay? And so this goes against everything I know. But since your book said it, we'll go with it. If the snake has been killed, bring it with you. We're in 2024. Just take a picture of it. I've actually done this before. When I was, again, in paramedic school in Mineral Wells, this kid got bit by a copperhead. It was a baby copperhead on the foot, again. And they had killed the snake, and they put it and so, like, they, like have the snake, like, held between, like, a branch. And they're like, oh, here's the snake. And they just, like, plop it in the back of the ambulance on the floor. And we're like, whoa, whoa, whoa. It's not necessary to bring that. I mean, your book's saying this, so I'm going to say, I guess if you see this on an exam, yes, bring the snake. But hunter's note, first off, let me tell you this. Dead snakes can continue to bite when you chop their head off. I've seen that, okay, for real. One, so, like, you could chop a snake's head off, and they can still be, like, biting, like little mutant aliens that they are. I hate all reptiles. And so, one, so that really does promote quite a danger. Like, seriously, like a snake, a pit viper that's still biting with their head chopped off. That's dangerous. One. Two, the snake itself, you could just take a picture of it. Like, or someone else, not me, is going to take a picture of the snake and just take that to the ER. A picture would suffice. I probably should delete it. I just so strongly disagree with taking a snake to the ER. And so let me tell you the story. Someone found a jar in this Mineral Wells call where they plopped the snake in the back of the ambulance. So they put it in a jar, and we put it in like we took it to the hospital. And the doctor like chewed our ass on this. It was like, oh, you don't need to do that. Get it out of here. Get it out of here. Right? And so it was like in like a true mason jar. So at that point, it was really pretty safe and it was dead. It was a small snake. But it's just, I think it's an inappropriate risk. Just take a picture of it. Oh, notify the patient, the hospital you're bringing a patient with a snake bite and transport promptly. This is actually incredibly important. And so watch out for this in the real world. So there is an antidote. What's an antidote? It's like a treatment to a toxin. In this case, a snake bite, to pit vipers. It's called crofab. And so if someone is bitten by a snake, you can give them this antidote that's incredibly expensive. It's about $28,000 for the wholesale cost to treat a patient with crofab. That's the first dose, and you do a continued doses. And it's very, very expensive. Very expensive, obviously. $28,000, the hospital's cost. Wholesale cost, right? We're probably charging the patient 50 to 100 grand for this, and so, or their insurance. And so the problem with crofab is, besides the fact that it's expensive, you have to reconstitute it. So it comes in a powder form, and you have to, like, a nurse has to reconstitute this and shake it and get it ready. And that takes, like, I think like 30 minutes to an hour. I can't remember. It takes time. I don't remember how long it takes to reconstitute crofab, but it does take time. And so the reason you want to notify a hospital if you're bringing a snake bite is two things. You want to make sure they have crofab and they have it in stock. Because if the Hillbilly Haven guy was beat by someone else yesterday at Hillbilly Haven that kicked a snake, they may not have any more because this is a very, very expensive drug. And so this isn't something you're going to keep 100 vials in your hospital. You're going to carry like enough for one snake bite at a time. And so you got to make sure they have crofab, one, and two, if it's a good hit, right, they may start reconstituting it then while you're en route to the hospital. Okay. So coral snakes, these are the really, really bad ones. And so these are small reptiles with a series of bright red, yellow, and black. And I think if it's Yellow and black, you'll kill a fellow, or something about Jack, or something. There's a rhyme that I should have looked up. I don't remember it. Look it up. Put it in the comments. And so it lives in most southern states. Okay, and so these are in Texas. And so it'll eject its venom with its teeth and tiny things by a chewing motion, chop, 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 leaving puncture wounds. I think if I got bit by a snake, I'd probably die of hysteria before the toxin. I would be hysterical. And so, coral snake venom is a powerful toxin that causes paralysis of the nervous system. So the other ones are like cytotoxic, more like blood thinning, local tissue destruction. The coral snake one is the one that's more likely to kill you with like like you'll stop breathing because of the neuro tissue issue with it, right? And so, within a few hours of being bitten, the patient will exhibit bizarre behavior, progressive paralysis of eye movement and respiration. And so there is antivenom for specifically coral snakes, but a lot of hospitals don't carry this. Emergency care is the same as a hip bite for bite. Now, before we get off of snake bites, let me stop. Did you notice anywhere in this lecture that I talked about ice packs? No, we did not. So ice packs are not currently recommended. Did you notice anywhere in this lecture that we talked about cutting an X pattern and sucking the venom out? No, I did not. Did you notice anywhere in there that we talked about splinting of the extremity? No, we did not. So notice those are not the treatments for these generally. Okay, so any of those wise tales you used to hear, delete them. Scorpion stings. You're starting to see these a lot actually in new build homes, right? So people are building their homes in deserts, and so their scorpion friends are moving back into their homes, and so you'll be aware of this. So obviously these bites are very painful, but they're not dangerous. And so there's this very scary. The scorpions are like alien looking as well, and so there's a stinger in their tail, and they'll sting you. Okay. Now I think the thing about a scorpion is they can sting you multiple times. Yeah. And so yeah. Wait, what was that saying? The exception of this, where they're painful but not lethal, is the Centroides sculpturatus, right? That scorpion apparently is very venomous. And so you could have, it sounds like it's a neurotoxic. So you have circulatory collapse, muscle contractions, excess salivation, and hypertension, convulsions, and cardiac failure. Hang with me. Now, tick bites. So again, these are common, and these are in fact, when we say Lyme disease in every state in the United States, by the way, in some way. And so these are tiny insects that usually attach directly to the skin, and they're found often in brushes, shrubs, trees, sand dunes, or other animals. And so they're very small, right? They're like the size of well, that's way too big. They're like the size of a period, right? So they're very small. And so the problem with a tick bite, besides being bit by something, is they carry this bacteria called Borrelia burgdorferi, also known as Lyme disease. And so watch for a vignette where they tell you, oh, the patient just came back from summer camp. Oh, the patient just came back from a camping trip. Oh, the patient just came back from a hike. Oh, the patient just spent a week at a lake. Something like that. Or the patient just come back from four-wheeling in the sand dunes. Watch for that when they tell you the patient had outdoor activity, okay? Now, the hallmark of Lyme disease, although this does only happen in like half of patients, but you'll see this on exams. That's a tick, by the way, very small. You'll get what's called a bullseye rash. And if you know anything about like shooting or anything, like this is a bullseye, right? And so you want to shoot here, right? And so they say this looks like that. And so that's called a bullseye rash, okay? Or a bullseye pattern. And so be aware of that. If you see them tell you there's a bullseye pattern, tick bite, Lyme disease, that's what it is. There's a few other times this can happen, but in EMT level, this is what they're trying to push you to do. Think, oh, that's a tick bite, okay? And so Rocky Mountain spotted fever is different, but you can get Rocky Mountain spotted fever from a tick bite as well. This is called Rickettsia rickettsii. It's also a bacteria. It's a spirochete. It's treated with doxycycline. And so basically it occurs every 7 to 10 days after the bite. And so you're going to get like these prodromal symptoms, these just general symptoms of nausea, headache, vomiting, weakness. But this can lead, this would be rare, to paralysis and cardiorespiratory collapse. I will say about Rocky Mountain spotted fever is it's one of the few times you'll see what's called a palms and soles rash, where you'll see a rash on the palms and soles. That's one of the few times you'll see this. Also, you'll see that in syphilis, which is an STD. And so again, Lyme disease is also from a tick bite. And so also Borrelia Rocky Mountain spotted fever, this is in the Appalachians. This is where it's most common. So you're like, what? The name is Rocky Mountain, like Colorado. No, no, no. I know. I did not name this. Rocky Mountain spotted fever is in the Appalachians, okay, which is like Virginia's and all the Appalachian states, right? So that's like the east or the East Coast, okay, not the actual Rocky Mountains. I think it is terribly evil whoever named this, but they're not. I mean, it's really weird. You don't see this in the Rocky Mountains. You see this in the Appalachians. Now, Lyme disease is in every state except Hawaii. And so you'll get, again, these prodromal symptoms, fever, flu-like symptoms, right? That bullseye's rash, if you see that, that is specific enough at this level for you to think, oh, that's Lyme disease caused by tick bites. And here's the hallmark of Lyme disease. And this happens over years. This doesn't go away usually. This is like a chronic disease. I actually have a friend who's a firefighter whose wife's disabled from this, like truly disabled, like not milking disability, but like truly disabled from Lyme disease. And so um, the joints hurt. So this bacteria is a spirochete, and so it goes into the joints and it causes all these problems for joints, especially like the knees and the elbows. And so it gets confused with like rheumatoid arthritis because it presents very similarly in the knees and elbows. They get swelling and it looks like arthritis. So just be aware of that. Okay, this can be treated with doxycycline for like 100 days or more. But it's very, very hard to eradicate because of this, the shape of this bacteria and the way it lives. It's very, very hard to treat this, to cure it. So a lot of patients will suffer with this for the rest of their life. Other thing to know is generally the tick has to be attached for 24 hours or more for there to be a successful transmission of the bacteria. So a tick bite that's only been 5 minutes, you're not going to get Lyme disease. A tick bite that you find 2 days later might have Lyme disease. Now, this again typically happens in the summer months, so if transport will be delayed, remove the tick by using fine tweezers to grasp that sucker's head and pull it straight out, okay? You don't yank at an angle, it's just straight up, okay? Once the tick is removed, cleanse the area with antiseptic and save the tick for identification. Now, it's called the dermocenter wood tick that this is carried in, the useful stuff I have to learn in medical school. And so there are different ticks that if someone wants to, you can take a picture of this or whatever. It or wait, it's Exodes wood tick. It's Exodes wood tick. Dermocenter. I think it's the derm. There's two ticks. Now I have them confused. Anyways, there's two of them that can carry this, and so or that they carry rickettsia and carry Lyme disease. Anyways, not all tick bites carry these bacterias, and so this is where identifying what the tick was and how long it was on there could be helpful for the diagnosis. Now again, you're like, what? Marine animals? We're in Texas. We're in Dallas-Fort Worth. I know, but this is a national exam. So marine animals is the last bit, and we're going to do the questions. I know this has been a long one. I'm tired of talking. And so coal enterics are responsible for more envenomations than any other marine animals. So examples would be like fine coral, the Portuguese man of war, sea wasps, sea nettles, true jellyfish, sea anemones. I feel like I'm saying that wrong. True coral and soft coral. Okay. These things, yeah, you wouldn't want to be stung by these. Be careful. I don't have a lot to add. I'm not an expert on these. So I think we've seen people though in the movies and stuff. They get bit by like or not bit, stung by like jellyfish and stuff. So it's very painful. Sometimes you'll see like lesions from the tentacles. So they're gonna have headache, dizziness, muscle cramps, fainting. Really, the issue is how painful they are. And so you would want to limit the discharge of nematocyst by avoiding fresh water, wet sand showers, or careless manipulation of the tentacle. Keep the patient calm. Reduce the motion of affected extremity. You can remove the remaining tentacles by, again, we scrape them off with the edge of a sharp, stiff object like a credit card or something like that, and provide transport to the emergency department. I don't have a lot to add on that. I'm sorry, I'm not an expert on marine animals. And so review time, let's wrap this up. When a person is exposed to cold temperature and strong winds for an extended period of time, he or she will lose heat mostly by, okay, I'm going to think that the key word of this is strong winds, because strong winds can really cool you off. We've all been there, right? And I know that when I turn on my oven to bake a delicious cake, which I'm going to do tomorrow, I use my convection setting because it circulates the air in there so it cooks more evenly. So I'm going to say this is convection. Booyah. Food Network helping me out. Okay, so yeah, convection, remember, I always think of a convection oven. It moves air in your oven to cook your food more evenly. And so, again, when they say it's very windy, you need to think, oh, that's convection. okay? Wind equals convection. You can screenshot these, okay, just as we always do, or you can pause the video. Shivering in the presence of hypothermia indicates that, okay, let's whip through these. The musculoskeletal system is damaged. No, it's not. It's working. It's doing what it's supposed to do. We're trying to generate heat by shivering. Because remember, muscle movement generates heat. Nerve endings are damaged, causing loss of muscle control. No, they're working because they're contracting. Um, the body is trying to generate more heat through muscle activity. Yes. The thermoregulatory system is failed and body temperature is failing. No, that happens only in severe hypothermia when you are like I think it's like less than 92 degrees is when you'll have cessation of shivering. It's been like 2 weeks since I did the first video. Booyah! See, good. Okay? Shivering generates heat through muscle contraction. It's normal, and we only see this in early hypothermia. In late hypothermia, this will cease. It'll stop. All the following are examples of passive rewarming. Whoops, come on, do it. Except, so passive meaning it's not active rewarming like hot fluids and stuff like that. Removing cold and wet clothing, that would be passive. Administering warm fluids by mouth, that is active. You're administering something. You're actively doing that. Turning up the heat inside the ambulance, that's passive. Covering the patient with warm blankets, that's passive. So again, you could just delete you can get here by elimination. I'm not even celebrating that one. I felt like that one was pretty easy. A woman has frostbite in both feet after walking several miles in a frozen field. Her feet are white, hard, and cold to the touch. Treatment at the scene should include rubbing her feet gently with your own hands, awfully kind, maybe. Trying to restore circulation by helping her to walk around. No, that could cause further damage. That's wrong. Removing her wet clothing and rubbing her feet briskly with. No. Removing her wet clothing and covering her feet with dry, sterile dressings. Yes. The reason I think so, this is so far frostbite, where they're white, hard, and cold to the touch. Sometimes they'll describe this as waxy. I think that the damage has been done. And by any type of manipulation, like rubbing or anything like that, it could further cause tissue damage. Booyah. It's almost like I've been to EMT school. Good. Call me butter. I'm on a roll. All right, 30-year-old male who has been playing softball all day in a hot environment complains of weakness and nausea shortly after experiencing a syncopal episode. What's a syncopal episode? It's a fainting episode, all right? Appropriate treatment for this patient includes all the following except giving a salt-containing solution by mouth. Generally, you don't want to give something by mouth. Moving him to a... So I'm going to put a question mark on that. Moving him to a cooler environment at once. Yes, you definitely want to do that. So... administering oxygen via non-breathing mouth, yes, you would want to do that. Placing him in a supine position and elevating his legs. Yes, you would want to do that as well. So yeah, I'm going to say the salt. I hope I didn't curse myself with my cockiness in the previous answers. Booyah! Yeah, you don't get stuff by mouth, especially with nauseated patients. It increases the risk of vomiting. And aspiration. Remember aspirations when someone vomits and they don't protect their airway, so they like kind of choke and swallow, or not swallow, but they inhale their vomit. So that creates a huge list of problems. Imagining swallow or inhaling vomit. All right. You're assessing a 27-year-old woman with a heat-related emergency. Her skin is flushed, hot, and moist, and her level of consciousness is decreased. After moving her to a cool environment, managing her airway, and administering oxygen, you should. So this sounds like heat exhaustion, not heat stroke, not heat syncope. She's just hot, right? She's been at First Monday, right? Or not First Monday, the Peach Festival. It's hot, okay? And so... God, I'm probably going to get this wrong. Okay, give her ice water to drink. Maybe not immediately. Place her in the recovery position. I don't think her level of consciousness is decreased. Give her or cover her with wet sheets and fan her. I think that would be a little aggressive. That's usually more like heat stroke, so I think that one's wrong. Again, guys, I haven't looked at these. Take her temperature with an auxiliary probe. That would be helpful. That would be helpful to know the temperature, and it would be a good next step. I get gun shy getting these wrong on camera. I think I would do, I'm gonna go D. Don't listen to Hunter. I actually need to start looking at these pairs. Okay, you'd cover with sheets and fan her. I got it wrong. Jeez. Okay, the patient heat stroke. She's still sweating. The level of consciousness decrease, maybe. Okay. Okay, just read it. The patient experiencing heat stroke. After moving her to a cooler area, manage her airway and administering oxygen. The single most important is to rapid cooling. Turn on the AC in the back of the ambulance, cover with a wet sheet, and begin fanning her. Consider applying chemical packs to her groin and axilla. Follow the local protocols. A treated heat stroke is almost always fatal due to brain damage. Don't listen to me. One day I'm going to get them all right. All right, learn from my mistakes, folks. Learn from my mistakes. All right, it is important to remove a drowning victim from the water before laryngospasm relaxes because it's important to remove it. So remember, when someone drowns or goes submerges in water, the larynx, the vocal cords will slam shut. Okay, and so it's called a laryngospasm. And so the idea is when someone is still alive, they'll have laryngospasm, but as you die, obviously everything relaxes, and that spasm will relax to where water can go back into uh, the airway. And so um, I would say C because less water will have entered the patient's lungs. Yeah. So remember, laryngospasm is a reflex to where the larynx, the vocal cord slams shut, so no water or air will go back there when someone's submerged in water. But as you begin to die and deteriorate, that spasm will relax as all muscles relax because you're dead. And so you could end up with water entering the lungs, and that creates a whole nother list of issues. A 13-year-old boy is found floating face down in a swimming pool. Witnesses tell you that the girl has been practicing diving. Sounds like spinal cervical trauma. After you and your partner safely enter the water, you should. Okay, turn her head. No, that's definitely going to be wrong. Turn her head. I'm going to be reading the rest of the problem. It's wrong. Rotate her entire body as a unit and carefully remove her from the pool. Yes. Rotate her upper half of the body as a unit, supporting her head and neck. I would say the whole body. I mean, you would never keep the spine out of line. I would say the entire body. This is getting embarrassing. I need to start reading this. Rotate her entire upper half of the body as a unit, supporting her head and neck. When caring for a patient who is in the water and has possibly been injured, rotate the upper half of the body as a unit, supporting the head and neck until the patient is face up. Open the airway and jaw thrust maneuver and begin artificial ventilations. I can't imagine this. When caring for the patient who's in the water and has body as a unit? That doesn't make sense to me. Well, who am I? I'm getting them wrong. So let's read the rationale. Um, let's see the one that I chose. So while in the water and placing the patient in the supine position, a controlled rotation of the upper torso automatically causes proper rotation of the lower torso. Are y'all reading this? It makes sense, right? If you were to rotate someone's upper torso in water, since there's little resistance, the lower body's going to go with it, but that's still resistance. I don't know why you wouldn't move the whole body as a unit, or at least try to. I used to think these questions were fun and cool. I'm reneging on that. No more. Shortly after ascending rapidly to the surface of the water while holding his breath, if I get another one wrong, I'm going to be devastated. Shortly after ascending rapidly to the surface of the water while holding his breath, a 29-year-old diver begins coughing up pink frothy sputum and complains of dyspnea and chest pain. You should suspect and treat the patient for, I would say, okay. So this is an ascent injury, right? And so when you hold your breath, you risk an air embolism. That's a great risk. A pneumothorax is also a risk as well. But since they're saying it shortly after ascending, he's not bent, so it's not decompression sickness. Remember, decompression sickness takes place like an hour or so or more after you come to the surface. A pneumomediastinum would be astronomically rare. You'll see this in esophageal rupture, right? When the food tube ruptures in the back of the throat. And so I don't think that's it. That's like very fatal, by the way. A pneumothorax. This is possible. This is quite possible. But the thing that's keeping me from thinking that may not be it is the fact that he's coughing up pink frothy sputum. To where I would think this is more likely going to be an air embolism. A pneumothorax is very possible, though. What would make me choose a pneumothorax over anything else is if they say that there was diminished breath sounds on one side or absent breath sounds. They didn't say that. And so, God, I hope I don't get this wrong. I'm going to go with an air embolism. Yes. Okay. Thank gosh. All right. Good. Air embolism. Remember, these happen really rapidly after ascending. Remember, there's gas bubbles in our blood, and if you go up really quick, those little bubbles become big bubbles. It can be one big bubble. That's an air embolism. If it travels to your heart or lungs or brain, right, you can end up with issues, especially the lungs. Okay. Ooh, good. A triage question. So 3 ambulances responding to a golf course where a group of 6 golfers were struck by lightning. Yikes. Okay. By the way, golf clubs make excellent lightning rods. And you're in an open field. So yeah, don't go golfing in severe weather. And so 2 of the golfers are conscious and alert and have superficial skin burns. So remember, the walking wounded are green. So those patients are fine. So let's do this. Let's have a little fun. 2 of the golfers are conscious and alert. And so that's group 1, right? And then so the next 2 golfers have minor fractures and appear confused. So those are our yellows. The last 2 golfers are in cardiac arrest. Okay, I don't have a black. I think I do here. So the last 2 golfers are in cardiac arrest. So those are black tagged, right? So according to reverse triage, which of the following should be treated first? So treated first would be group 3, the black group, okay? And so that's a black tag, and so we would, or an expectant, as you would call them. And so I think that group 3 would be treated first because of reverse triage, because lightning's involved, so we use reverse triage. And they even told you in the question to use reverse triage. So I'm going to go C, group 3, final answer. Boom. Okay, now that's how that's tested. I told y'all that they like to test that. And so be aware of reverse triage. Anytime they use the word lightning, dead people are the highest priority if we suspect they were struck by lightning. Okay? And that's it. Okay, very long video. Appreciate y'all's attention. That's the end of environmental emergencies. That's the end of the trauma chapters. Bye.